Good morning, everyone. So, today I will talk about a very huge topic, actually, which is the ABGs. I need not one lecture, need lectures, but I tried hardly to make it easy and practical. So, I hope it will be helpful. So, I will start with what is an ABG. ABG test is a blood test that requires a sample from an artery to measure the levels of oxygen and carbon dioxide in the blood. The test also checks the balance of acids and bases. What's the components of ABG? What I'm getting when I'm doing the ABG sample, I will know the pH, is my body is acidic or alkali, BaCO2, the partial pressure of the carbon dioxide, the BaO2, partial pressure of the oxygen, SCO3, O2 saturation, and the base excess. The normal ranges, which we'll use later, the pH will be 7.35 to 7.45. Anything below the 7.35 will be acidic, and anything above will be alkali, above the 7.45. The BaCO2, the partial pressure of carbon dioxide, is 35 to 45 millimeter mercury. BaO2, 75 to 100. HCO3, 22 to 26. O2 saturation, 95 to 100%. Base excess, plus minus 2 milli equivalent. So we are facing in the ER a lot of cases which we require to do an ABG. So I started with these indications. Some of them we are using, some of them in another departments, mostly in the ICU. The first thing and the most common we are facing is the respiratory failure, either it's acute or chronic, as in asthma or a COPD patients. Any severe illness which may lead to a metabolic acidosis, for example, cardiac failure, liver failure, or renal failure. Hyperglycemic states associated with diabetes mellitus, as DKA and osmolar hyperglycemic state. Multi-organ failure, sepsis, and burns. When we are suspecting poisons or toxins in the ICU, in ventilated patients, and also in sleep studies, and in severely unwell patients from any cause, as its affect prognosis. If there is underlying acid-base disturbance, if we correct it, it affects the prognosis. So, what's the procedure? Arterial blood can be obtained by direct arterial puncture, most usually at the wrist, radial artery. Alternatives to the radial artery include the femoral and brachial artery, both of which are usually used in emergency settings. The dorsalis pedis artery and the ulnar artery may also be used. It's important to ensure good collateral circulation, as there is a theoretical risk of thrombus occlusion. If multiple samples are required, then an indwelling arterial cannula can be placed. If the patient is on oxygen, titrate with oxygen for 5 to 10 minutes before taking the ABG sample. 30 minutes, we have to stop the oxygen if they have a chronic COPD and they are dependent on the oxygen before taking a sample. Acid-base balance. It's mostly what ABG talks about. The body produces acids daily, 15,000 millimole CO2 and 50 to 100 milliequivalent non-volatile acids. The lungs and kidneys attempt to maintain balance. Buffering also occurs in the liver through ammonia metabolism to urea or glutamate. How? The kidneys have two main ways to maintain acid-base balance. Their cells reabsorb bicarbonate from the urine back to the blood, and they secrete hydrogen ions into the urine. By adjusting the amounts of reabsorbed and secreted SCO3 and H+, they balance the bloodstream's pH. So, The HCO3 is the alkali, the bicarb. So if I keep it in the body, I will maintain more alkali. If I will excrete it through the kidney, so I will decrease the alkali and increase the acidic in the blood. The pulmonary system adjusts pH using carbon dioxide. Upon expiration, carbon dioxide is projected into the environment. Due to carbon dioxide forming carbonic acid in the body, when combining with water, the amount of carbon dioxide expired can cause pH to increase or decrease. So carbon dioxide, the CO2, which is we excrete through exhalation. So if we accumulate it, it's an acid. So accumulation of CO2 will make more acid, and if we exhale it, will be less, and later we'll see it in practical. In addition to the kidneys and lungs, the liver also plays an important role in the regulation of acid-base balance. The involvement of the liver in the regulation of acid-base balance is crucial because of its role in lactic acid metabolism, urea production, and in protein hemostasis. So I will start with the respiratory acidosis. From the name, it's a respiratory, then the problem in our lung. As it's acid, so the pH will be less. And as it's respiratory, then the problem in the carbon dioxide. So there is a problem happens. My CO2 is not going out from my lung, so it accumulates. This increase in the CO2 will make the pH to go down. So this is what's called a respiratory acidosis. And mostly it happens when my ventilation is less. So I'm not exhaling enough CO2. Causes, the most common causes, CNS depression, pleural disease, COPD, ARDS, musculoskeletal disorders. Compensation for metabolic alkalosis. When I have a metabolic alkalosis, my body will try to compensate by increasing the CO2. Respiratory acidosis has two parts, acute and chronic. Acute, the most common presentation as asthma. An acute presentation of respiratory acidosis, slight renal involvement, buffering via titration, via HP, buffering of hydrogen ions. For example, HCO3 will increase 1 milliequivalent for each 10 millimeter mercury in BCO2. In a chronic, like COPD patients, chronic renal compensation will be via synthesis and retention of HCO3, decrease chloride to balance the charges, hypochloremia. So in the chronic, the HCO3 will increase 3 milliequivalent for each 10 millimeter mercury in BCO2 as a buffering system. So I have acidosis, my body will try to keep the HCO3, which is the alkali, to compensate. Respiratory alkalosis, from the name again, alkalosis, then the pH is high, the CO2 is less. So what's the most common mechanism? That I'm breathing fast or more frequent, so there is increase in the ventilation, so I'm exhaling more CO2 will be less, which is the acid, so my body will be alkali. The chloride here will increase, not like in respiratory acidosis, to balance the charges, so hypercholoremia. Again, acute with chronic. In the acute here, the HCO3 will decrease because already my body is alkali. So I want to excrete HCO3 by 1.5 milliequivalent liter for every 7.5 millimeter mercury in BCO2 decrease. Chronic ratio increases to 3 milliequivalent liter of HCO3 for every 7.5 millimeter mercury in BCO2. Decrease renal bicarb reabsorption and decrease ammonia excretion to normalize the pH. What's the causes? There is a mnemonic called CHAMPS, the C, which CNS disease, intracerebral hemorrhage, cirrhosis, the H for hypoxia, A for anxiety, and this is one of the most common things, as the anxiety can cause hyperventilation. M, which is more ventilation or hyperventilation also. Progesterone for the P can stimulate respiratory centers. The progesterone, especially during pregnancy, So they will sometimes suffer from a chronic respiratory alkalosis and salicylate and sepsis. We finished the respiratory part. Now I will go to the metabolic part and fast. Metabolic acidosis. When my lung is not the main problem, my body has a problem, my lung will involve to just to compensate as a buffering system. From the name, metabolic acidosis. Acidosis pH again down. HCO3 is less. As I mentioned, HCO3 is the alkali. So when I lose it, my body will be acidic. So less pH and less HCO3. It takes 12 to 24 hours for complete activation of respiratory compensation. Decrease in BCO2 by 1 to 1.3 millimeter mercury for every 1 milli equivalent per liter HCO3. My body is losing HCO3, and because it's acidic and the CO2 is acid, so I will lose it as compensation. The degree of compensation assists via the Winter's formula. Winter's formula, and later I will apply it also, is very important in the metabolic acidosis to see if it's compensated or not compensated, and it helps also if I have another acid-base imbalance associated with it. How we do it? BCO2 equal 1.5 HCO3 plus 8 plus minus 2. There is a shortcut, actually, sometimes we can use it, but it's not always correct. For this formula, the expected BOCO2 is approximately equal to the last two digits of the BH plus minus 2, but it doesn't work always. Here, I will talk about the anion gap fast because it's a very important thing also in the ABG, which also the anion gap requires a separate lecture, but in fast. What is the anion gap? The anion gap measures the difference or gap between the negatively charged and positively charged electrolytes in your body. And keeping this difference is vital for our body. How we do it? The most easy one will use sodium minus chloride plus carbonate, bicarbonate. Sometimes we are adding sodium plus potassium minus chloride plus bicarbonate. The normal range is from 8 to 12 milliequivalent per liter. Metabolic acidosis, this is something we are seeing very frequent also. Why I mentioned the anion gap? Because it's important here. There is a high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. The high, like methanol, uremia, DKA, baraldehyde, isoniazide toxicity, iron toxicity, lactic acidosis, ethylene glycol, rhabdomyolysis, and salicylate poisoning, which we can use a mnemonic, mud bilers. And normal anion gap metabolic acidosis like hyperalimentation, acetoresamide, RTA, diarrhea, uretropelvic shunt, pancreatic fistula, and spironolactone use. Metabolic alkalosis, again, it's vice versa. pH is high, HCO3 is high, which is the alkali. BCO2, this is a buffering, will increase the acid to compensate the alkali by 0.6 to 0.7 millimeter mercury for every 1 milli equivalent per liter increase in HCO3. Causes, there is a mnemonic also called clever PD. The C is contraction when large volume of, it's called contraction of alkali, when large volume of sodium-rich bicarbonate low fluid is lost from the body. It's mentioned here twice. Most common cause is the diuretic. Licorice, which is we use it a lot in our region, especially in Ramadan. This is just a drink, causes this. Endocrine cones, Cushing Barters, vomiting, angiosuction, excess alkali, refeeding alkalosis, post hypercapnia, diuretics, and chronic diarrhea can cause the metabolic alkalosis. Last one, the mixed acid-base disorders. Mixed acid-base disturbances are combinations of two or more primary acid-base disturbances. These mixed disorders include combinations of metabolic disorders as vomiting-induced metabolic alkalosis plus hypovolemia-induced lactic acidosis, mixed metabolic and respiratory also as metabolic acidosis and respiratory alkalosis in salicylate intoxication. Here, this corrected bicarbonate, we use it. There is a lot we can use in the ABG. There is something called delta gap, many formulas. I have chosen the most easy one. It helps to detect if we have more than one acid-base disturbance. We will use this one corrected by carb. We will measure the anion gap minus 12 plus the serum HCO3. If it's more than 30, then there is also an underlying metabolic alkalosis. If less than 23, then there is an underlying normal anion gap metabolic acidosis. And also now we'll apply it. Last thing to discuss, osmolar gap. Osmolar gap also in ABGs is important. When I'm using the osmolar gap, when I have a raised anion gap, high anion gap metabolic acidosis, what's the common causes? As I mentioned now, the mid bilers, but here I will mention few: ketones, lactate, renal failure. If I have a high anion gap and no one of the common causes is present, and I have ingestion possibility, then I will go to measure the osmolar gap. If it's raised, then there is the patient has ingested something. The most common is ethylene glycol and methanol. If it's normal again, then this is salicylate or iron toxicity or isoniazide toxicity. So how we will measure it? Measured osmolality minus calculated osmolarity. This is a very detailed topic, osmolality and osmolarity. This is millimole per liter and per kg. Anyway, how we are doing this calculated osmolarity, 2 by Na plus glucose plus urea. It should be below 10. If it's more, if I have a high anion gap metabolic acidosis, I will measure it. It should be below 10. If it's above, then the cause is methanol, ethylene glycol, sorbitol, mannitol, glycine. This is we see in the TURP procedure, transurethral resection of prostate, as they are using for irrigation, propylene glycol, polyethylene glycol, and maltose as in IVIG. The steps, how I will read ABG. Also, it's a huge, but I will make it fast. I will start with the pH. It's below 7.35 or above 7.45, acidic or alkalic. The first thing I will look towards is the BCO2. The BCO2, high or low, then I'm talking about a respiratory. Then I will check if there is a compensation. If not, then my eye has to go direct to the HCO3 to see this is metabolic or not. Look for disorders revealed by failure or compensation, calculate anion gap, and calculate corrected by CAP. So I just chose 4 samples and fast. Sample number 1, an ill-appearing alcoholic male presents with nausea and vomiting. So his pH, actually, I corrected it then again. The pH is 7.3. Then it's acidosis. Here are the normal ranges. So I will look at the BCO2. BCO2 within the normal range. Then this is not a respiratory problem. Mostly. HCO3 is the normal is 22 to 26. It's less. Then I'm losing alkali, and that's what's caused acidity. Then we are talking about a metabolic acidosis. So it's a metabolic acidosis. I will direct measure the anion gap when I have a metabolic acidosis. Am I dealing with a high anion gap or a normal anion gap? How we are measuring the anion gap? Na plus chloride plus HCO3, 137 minus, 90 plus 21, it's 24. So this is a high anion gap. When I have a metabolic acidosis, I will use the Winter's formula, which I use 1.5 by HCO3 plus 8 plus minus 2. Here, the Winter's formula is 39, 1.5 plus 21, the HCO3 plus 8 plus minus, it's 39 plus minus 2. So my BCO2 is 40. So by Winter's formula, 39 plus minus 2, so 41 or 37. So this is a compensated. If it's above this number or below this number, now I will talk about it. So this is a compensated. This is also a separated topic, compensated, partially compensated, but let's take it like this. This is a compensated from respiratory point of view, and there is no association of a primary. It's not just CO2 is trying just to compensate. There is no separate respiratory acidosis or alkalosis. Then I will see the corrected bicarbonate. The corrected bicarbonate, as I said, the anion gap minus 12, it's 13 plus HCO3, 21, 34. So in this case, there is with the metabolic acidosis and metabolic alkalosis as a primary. So here, this case, we are talking about a mixed acid-base disorder. So this is the way how I came to know. I came to know what the first was it. What is it? Anion gap, Winter's formula as its acidosis. Then the corrected bicarbonate. So this is alcoholic, and nausea and vomiting. So the alcohol itself can cause a metabolic acidosis and a raised high anion gap metabolic acidosis. Nausea and vomiting, he's losing HCl. So there is also a metabolic alkalosis together. Sample 2, 22-year-old female presents for attempted overdose. She has taken an unknown amount of Midol containing aspirin, paracetamol, and caffeine. On examination, she is experiencing respiratory distress. pH 7.32, below 7.35, acidosis. BCO2, normal, so it's low. PO2, so if I will look at it like this, I will say this is a respiratory acidosis. HCO3 is 14. It's acidosis. Then this is a metabolic acidosis case. Now, when the next slide, I will tell you what's this case, because this is a confusing case, so I choose to talk about it. So this is a metabolic acidosis case. I will measure the anion gap, as we mentioned before. It's a normal anion gap, so I will exclude all these causes. I mentioned that the patient has took unknown amount of aspirin containing. So we are talking about salicylate poisoning. So I'm dealing with metabolic acidosis. Winter's formula. 1.5 by HCO3 plus 8 plus minus 2, 25 plus 0.5 plus minus 2. So here, how much my CO2? 18. By Winter's formula, I reached 25 plus minus 2. So 27.5 or 23.5. So it's above, it's uncompensated. It's not in the range of the 18. And it's above. When it's above like this, 25 or 27, then it's uncompensated, and we consider a primary respiratory alkalosis, which is the case. If I have a salicylate poisoning, aspirin overdose, the presentation mostly will be a metabolic acidosis associated with a primary respiratory alkalosis not dependent to each other. Correct the CO3 to know if there is another metabolic disorder. 19 minus 12, 7. The 7, H24. Just a reminder, above 30 or below 23, it's 24 in the middle, so I'm expecting no additional deficit. So from here, we came to know what's the importance of the Winter's formula. If you see this case, you will look at the pH, acidosis, here acidosis, here acidosis. Sorry, alkalosis, here acidosis. So the Winter's formula helped me to know this is a primary respiratory alkalosis with a metabolic acidosis. Sample 3, 47-year-old male experienced crush injury at a building site, 7.34 acidic, BCO2 31 is low. When I'm losing CO2, then I'm losing the acid. Then I will go to the HCO3. HCO3 is 15. Then I'm talking about a metabolic acidosis. Metabolic acidosis, I will measure the anion gap, Na minus chloride plus bicarb. It's 22. It's a high anion gap. So when I go back to the causes of high anion gap, high anion gap metabolic acidosis and patient has crush injury. What I will remember the rhabdomyolysis. We will apply the Winter's formula, 1.5 by 15 plus 8 plus minus 2. It's 30.5. We'll go back. 31.5 is the patient's PCO2, so it's compensated. Corrected by carb, 22 minus 12 is 10, 10 plus 15, 25 expected, no additional deficit. Last one, 1-month-old presents with projectile vomiting for 2 days. ABG, 7 point, this is as the simplest, 7.49, alkalosis, BCO2, 35 to 45, normal, HCO3 is elevated, then this is a metabolic, sorry, then this is a metabolic alkalosis. And chloride is low, and even the potassium is low. The baby is vomiting. So this is just a simple metabolic alkalosis, hypochloremic. Thank you very much.